Bulbar palsy. You want to talk about bulbar palsy? Okay, well, we can talk about bulbar palsy versus Bell's palsy. And we'll talk about pseudobulbar palsy as well, from the perspective of an anatomist. So we can talk about the neuroanatomy side of things here. What this is really letting us do is it's letting us talk about cranial nerves a bit more, review some cranial nerves and lump them together, link them to signs and symptoms that you might see in patients, and it gives us a chance to talk about upper motor neurons and lower motor neurons as well. So it's kind of adding to that whole understanding, full package, big picture thing, all right? That's what we'll do. We'll come in gently. What do we mean when we say palsy? Well, we mean a paralysis or weakness of muscles as a result of damage to the nervous system. This could cause tremors as well, so it could cause, contraction and relaxation of muscles, causing a tremor, causing movements. It could cause a spasticity, so a stiffness of the muscles. They have more tone than normal. And this could be caused by a number of things. It might be caused by a disease of the nervous system, like a motor neuron disease. So motor neurons are the neurons that are going to innervate the muscles. So if they're injured by a pathological process, that's a motor neuron disease. It could be caused by trauma, damage to a peripheral nerve or damage to the central nervous system, the brain or the spinal cord. It could be because of infection by a virus or a bacteria. Neurons are cells of the body. They can be damaged like other cells of the body by pathogens. Or the neurons could be damaged by ischemia. This is a particular issue with the brain. We worry about stroke. We worry about an occlusion within a blood vessel, a blockage within an artery, then limiting blood flow to part of the central nervous system, causing those neurons to become ischemic and maybe damaging them temporarily or permanently. Bulbar. What's a bulbar palsy then? Well, bulbar refers to the shape of the medulla oblongata. So in the brainstem we have the medulla, the pons and the midbrain, and bulbar, I think it's an ancient Greek word. It's describing that shape, that bulbar shape, bulbous shape you're probably familiar with. So a bulbar palsy is specifically talking about a palsy associated with the medulla oblongata, and it's talking about the nerves that are coming out of the medulla, so the cranial nerves of the medulla, and particularly those that are motor neurons, motor nerves going to the muscles of the head and neck predominantly. The cranial nerves are numbered 1 to 12, and most of them come out of the brainstem. The first two come out of the cerebrum, but the others come out of the brainstem, and we number them sequentially as we descend. So 1, 2, 3, 4, 5, 6, 7, 8. Now cranial nerve 8, the vestibulocochlear nerve, is responsible for carrying balance information from the inner ear and the sensation of hearing. And cranial nerve 8 is going into the brainstem at where the pons becomes the medulla. So it's right on the edge of the medulla. Some of its nuclei are in the pons, some of them are on the edge of the medulla. But the vestibulocochlear nerve is a sensory nerve, and of course we're talking about a palsy. So a bulbar palsy, we're worried about motor function because we said that a palsy is paralysis or weakness of muscles as a result of damage to the nerves. So then after 8 we have cranial nerves 9, 10, 11 and 12, and all of those have motor functions. So bulbar palsy is talking about the motor output, the motor parts of the cranial nerves 9, 10, 11 and 12 coming out of the medulla oblongata. We should take each one of those in turn, but very briefly. Cranial nerve 9 is the glossopharyngeal nerve. Glosso, tongue, pharyngeal. We're talking about the lower motor neurons that are coming out of the brainstem. So a lower motor neuron is a motor neuron in a peripheral nerve. Cranial nerves are peripheral nerves. They're outside the central nervous system. Upper motor neurons are neurons inside the central nervous system, so linking that lower motor neuron with the primary motor cortex, for example. So, yeah, sure, the glossopharyngeal nerve innervates stylopharyngeus. So it has a role in moving the pharynx, but it does also have a number of sensory roles we should mention. It's the sensory limb of the gag reflex when an object passes to the back of the oral cavity and triggers the muscles there to contract. It's the sensory part of that. It's motor to the parotid gland for salivation. And the sensory roles of the glossopharyngeal nerve back in the pharynx there mean that it's important in the swallowing reflex, in the automatic movements of swallowing when you push a bolus of food to the back of the oral cavity and trigger a series of events where you swallow food safely and it doesn't go down the airway. Now that's the glossopharyngeal nerve. The vagus nerve, cranial nerve 10, is the nerve that's motor to most of those muscles of the pharynx, most of the muscles of the soft palate. So it has an important motor role in swallowing. So if we're thinking that we have a bulbar palsy affecting the glossopharyngeal nerve and the vagus nerve, then we're thinking that we might have dysphagia, difficulty eating, difficulty swallowing. And not only is a difficulty swallowing a problem for the patient, that swallowing reflex is an important safety mechanism, which means that food goes down the esophagus and not down the airway. The vagus nerve is also the motor nerve to the muscles of the larynx, which means that I'm making sound by moving my vocal cords with the intrinsic muscles of the larynx using branches of my vagus nerve, which means that, sure, you might find dysphonia, a difficulty making sound because you struggle to move one or both of the vocal cords, giving a hoarse voice, dysphonia, but also bringing those vocal cords together is an important part of the swallowing mechanism. I've talked about swallowing elsewhere in another video, but there's a series of movements whereby everything moves up and down and the food is passed to the esophagus, the airway is closed off by the vocal cords, as well as the epiglottis flapping over just to encourage food and water to go around it. But if the vagus nerve is injured, if the lower motor neurons of the vagus nerve are not working properly because you've got a bulbar palsy, then you worry about a safe swallow. You worry about aspiration of foreign objects down the airway. And this is dangerous because it can lead to infection and inflammation and pneumonia and ultimately death. It's a really important, it causes more deaths than many people think. The safe swallow is really important. Now, cranial nerve 11, the accessory nerve, its lower motor neurons are going to run to the sternocleidomastoid muscle and the trapezius muscle. Sternocleidomastoid is responsible for certain rotations of the head and neck, and trapezius is it's responsible for many functions, but it elevates the shoulder girdle, so shrugs the shoulders. So if there is a palsy of the accessory nerve, then rotation of the head against resistance, shrugging the shoulders against resistance will pick out that weakness and that paralysis. But after cranial nerve 11, the accessory nerve, comes cranial nerve 12, the hypoglossal nerve. Glossal refers to tongue, as I said, so hypoglossal, this nerve goes beneath the tongue. Its only job is to innervate the muscles of the tongue. And now we're back to swallowing and speech. We're back in the mouth. So if their hypoglossal nerve isn't working properly, then if they protrude their tongue, it may well deviate to one side or the other. If this has been going on for some time, you might see atrophy of the tongue. You might see fasciculations of the muscles of the tongue, a rippling movement as they move in a coordinated yet uncoordinated manner. But the patient will probably notice, swallowing is more difficult. So we're back to dysphagia, difficulty eating, difficulty swallowing, because the tongue is really important in moving food around the mouth for chewing, and it's important in pushing the bolus of the food to the back of the oral cavity to initiate the swallowing mechanism. So if the tongue isn't working properly, that contributes to dysphagia. And of course, I'm speaking to you now as clearly as I can, and I'm using the muscles of facial expression, I'm using the muscles that move my jaw, and I'm using the muscles in my tongue to make these words. So this is, well, if I was struggling to articulate myself clearly, this would be dysarthria. I've actually talked about these words before because they overlap so much, but dysarthria, so again, dysphonia might be a difficulty making sound. Dysarthria might be a difficulty in clear speech, producing clear speech, possibly because the tongue isn't moving, isn't as controlled as it should be. So you're identifying dysphagia, dysarthria, maybe dysphonia, maybe an absent gag reflex, but you may not even be testing for that, and an absent gag reflex can be a normal finding anyway. And this is leading you down the cranial nerve pathway of the cranial nerves of the medulla oblongata, and you're considering a bulbar palsy. What's the cause? There are many possible causes, so further investigations would be needed to find out the cause, but most of the time you're going to be managing those symptoms of the bulbar palsy. How is this different to Bell's palsy then? Well, Bell's palsy only involves cranial nerve 7. So we're up in the pons, or at least in the boundary between the pons and the medulla again. The facial nerve is a very, very busy nerve. It's the weepy, snotty, dribbly nerve of the face. But in the case of Bell's palsy, what's noticed most is that the facial nerve innervates the muscles of facial expression. It doesn't innervate the muscles of mastication, that is the muscles that move the jaw, the muscles that let you bite. Those are innervated by the trigeminal nerve. But the facial nerve will innervate the muscles of facial expression. It'll innervate the salivary glands down here, sublingual and submandibular. It'll carry the special sensation of taste from the anterior 2/3 of the tongue. It'll innervate mucosa in the nasal cavity. It'll innervate the lacrimal glands and make you cry, and so on. It'll innervate one of the small muscles in the ear. It's a very, very busy nerve. But in Bell's palsy, the presenting feature is paralysis of the muscles of facial expression, usually on one side. So again, these are lower motor neurons of the facial nerve because they've left the central nervous system, they're in the peripheral nervous system. So these lower motor neurons have been injured somehow and have created a palsy in that all of the muscles of facial expression are paralyzed or weak and the face is drooping. The eye struggles to close, saliva maybe leaks out from the mouth like in a drooling fashion. Now what's happening here? It seems that in most cases this is the result of an infection, and probably a viral infection, probably the herpes simplex virus. The virus is passing with the nerve, with the structure of the nerve, and the facial nerve, or at least the part of the facial nerve that innervates the muscles of facial expression, comes out of a bony canal here. There's the mastoid process, there's the styloid process. The hole here, the foramen there, is the stylomastoid foramen. When the nerve is inflamed, it swells, and if the nerve swells when it's inside that bony cavity, there's nowhere for it to swell to, so the nerve becomes compressed. And then you have Bell's palsy. That seems to be the most likely, most common cause. Now, I mentioned all those other functions of the facial nerve. Most of those other functions are intact because it's the part of the facial nerve that's about to leave the skull and run to the muscles of facial expression that is affected. The other branches of the nerve that are going to run to the lacrimal glands and the salivary glands and the anterior tongue and to the ear, they branch off earlier, closer to the brainstem. However, there may be other signs and symptoms if that infection has travelled further up, further towards the inner ear. So there might be a change in taste, like a loss of sensation from the anterior part of the tongue, but not necessarily. The dry eye, so we worry about the cornea in Bell's palsy. The dry eye isn't because the lacrimal gland necessarily stops secreting lacrimal fluid, it's because it's harder to close the eyelids together and keep the cornea moist. And likewise, The leaking of saliva from the mouth isn't because of any change in activity of the salivary glands down here. It's because it's hard to control the muscles of the lips. So often, and because the face is drooping, then there's often an opening of the lips and saliva builds up and drains out again, just because of the muscles of facial expression having been affected. But Bell's palsy might present with, or the patient might develop, a problem with loud sounds. So sounds are louder than they normally would be. Loud sounds are really loud. Loud rooms are difficult. There's a middle ear reflex, an acoustic reflex I've talked about in another video, where loud sounds trigger a relay through the vestibulocochlear nerve to the brainstem and back out through the facial nerve and the trigeminal nerve to the stapedius muscle and the tensor tympani muscle to dampen the movements of the ossicles and the tympanic membrane, to dampen the energy of loud sounds. All right, we've probably gone a bit detailed there. Let's pull back out again. The overlap exists then between bulbar palsy and Bell's palsy in that the tongue might be affected, but only taste. The movement of the tongue should not be affected in Bell's palsy. Speech, so there might be some dysarthria, but speech can be affected by Bell's palsy because you need to move the muscles of facial expression to speak clearly. And if the muscles on one side of the face aren't moved, well, you can't move them, then that might cause dysarthria, that might have an effect on your speech, but it's different to the bulbar palsy. Swallowing should be fine, that should be intact. So Bell's palsy is also a lower motor neuron issue, but it's just the facial nerve, and it's all of the muscles of facial expression on one side that have been affected are paralyzed or that's the palsy, whereas the muscles that move the jaw will still be intact. So a little similar, but quite different to a bulbar palsy. What about a pseudobulbar palsy? As the name suggests, a pseudobulbar palsy is very much like a bulbar palsy. But as I said, a bulbar palsy affects the medulla and affects the lower motor neurons coming out from the medulla to those muscles of the face and the neck that we were talking about. A pseudobulbar palsy presents with very similar symptoms, but it's an upper motor neuron problem. That is, the neurons that are running from the primary motor cortex through the corticobulbar tract down to the medulla oblongata, which will then trigger the lower motor neurons that come out to do their job. It's the upper motor neurons that have been damaged. Again, these could have been damaged by a neurodegenerative disorder, by stroke, by trauma. And because the upper motor neurons, for those cranial nerves that are coming out of the medulla, have been affected, the same cranial nerves have been affected. Cranial nerves 9, 10, 11, and 12 are going to be affected. So again, we might see dysphonia. We're probably going to see dysphagia. We'll see dysarthria. But the cause isn't here. It's up in here somewhere, in the tract running from here down there. The most common or most notable differences in presentation seem to be an emotional lability, like laughing or crying to inappropriate stimuli, or laughing or crying to levels disproportionate to the stimuli. So a change in emotion, which is more of a central function, right? So the injury is affecting something inside the central nervous system. And also, because this is an upper motor neuron disorder rather than a lower motor neuron disorder, the muscles of the face might be affected, and they might have more of a be more of a spastic palsy. The muscles might be stiffer. So we might be seeing some effects on the muscles of facial expression. Now, you guys know all about upper motor neurons and lower motor neurons, right? So elsewhere in the body, you would know how to determine if it's an upper motor neuron problem or a lower motor neuron problem by doing a tendon reflex tap, a tendon reflex test. And If you did a tendon reflex test and there was a lower motor neuron issue, you know that the reflex would be absent or reduced, because we're just testing that pathway from the stretch receptors to the spinal cord out through the lower motor neurons to the tendon, right? And if it was an upper motor neuron lesion in the brain or the spinal cord and you did the tendon reflex test, the reflex would be brisk. It would be stronger than normal, stronger than expected, maybe stronger than the other side, because the upper motor neuron that would normally be dampening that reflex is not functioning. So the reflex would be faster, brisker, more powerful than usual, right? How do you use that in the head when you're trying to determine whether you have a bulbar palsy or a pseudobulbar palsy? Well, I mean, you have the jaw jerk reflex, which I've talked about elsewhere up here, but the jaw jerk reflex is making use of the trigeminal nerve, which is not something we've been talking about. That's not in the medulla oblongata. That's not a bulbar thing. That's higher up. That's in the pons. So what do? Well, that's a very good question, and you're probably going to need more imaging, further investigations to determine whether it is a bulbar palsy, lower motor neuron, or a pseudobulbar palsy, upper motor neuron in that corticobulbar tract, and looking for the causes of the problem as a whole. There's no easy answer, but that emotional bit would clue you into it being pseudobulbar rather than bulbar. Bulbar is just those lower motor neurons coming out. Pseudobulbar, the central nervous system has been involved somehow, so other functions of the central nervous system might have been affected. But hey, we've managed to talk about all those cranial nerves again. We've talked about the brain stem, and we've kind of summed all that up. So that was a useful chat anyway. But bulbar palsy versus Bell's palsy versus pseudobulbar palsy, it's not easy, but it's pretty interesting. Well, I hope it was interesting. See you next week.